He's going to present to you on knee dislocation and multigamentous injuries. Please go ahead.
Good afternoon and thank you very much. Starting about knee dislocation. So knee dislocation is a common injury what you see in emergency room. But if you try to consider the full orthopedic spectrum of injury, it's not that common. So how common we think about knee dislocation? Knee dislocations account for about 0.02% of all orthopedic injury. This is a spectrum of orthopedic injury. But this has to be considered like an emergency because we'll have to reduce the knee, otherwise we'll have consequent injuries which are very, very dangerous and even can use bleed. So what is the common mechanism? Majority of the time it is a high energy trauma, which is a motor vehicle accident. Many of our knee injuries are following dipole injuries or motor vehicle trauma, especially the motorcyclists. They fall and then come with an injury. But when we have a sport-related injury, which is often coming to our clinics and picking up, it's not very uncommon, right? So we have to treat the sport person and it is our owners and duty to put them back into the position. So these actually are also addressed as they come to the emergency situation. So what we do, we have to do the initial assessment because these injuries have serious effect if not managed properly. So a high index of suspicion of the associated injuries, because knee dislocation is often associated with some other injuries which are very, very dangerous. We'll have to rule out the neurovascular injury, which is a common associate, and we'll have to look for the telltale signs whether the knee is reduced spontaneously. Because even with shoulder dislocation, sometimes the patient might tell that they had a dislocated shoulder, but when they come, the shoulder is reduced. Something like that, the knee also may be reduced, but you look for whether the knee was reduced in initial part before they come to the hospital, because otherwise we will totally miss it and we send the patient home to end up in kind of an amputation or whatever. And then we have to look for the range of movement stability assessment in the cases of acute dislocation, but it's quite difficult in the acute setting. So basically, even if the patient says that something went wrong and the knee couldn't go on, you look for these telltale signs. Say you look for a kind of bruise or kind of a dimpling around the knee joint, which will tell you the knee was dislocated and probably got reduced. So we have to look for these signs. So the problem is many of the knee dislocated injury, almost 30 to 50% of the knee injuries are with popliteal artery. And the next common nerve which is affected is peroneal nerve. So why does this popliteal artery get injured? As you know, the popliteal artery is feathered at 2 points. When it's at the hiatus, and other one is the soleus arch. So between these 2 points, the popliteal artery is fixed. So that is one of the reasons why this popliteal artery is injured in many of the knee dislocation. So it can be injured by means of a traction injury when the knee dislocated anteriorly, or when the knee goes behind, can cause transection of the popliteal artery. So only a high index of suspicion can solve this problem. The other one is common peroneal nerve. Because of its proximity to the knee, it can be injured by attraction. So only way to assess is the assessment. The patient will have to drop sensory loss and all. If you assess and document at the first stage, we know what to do next. Otherwise, we will end up in legal issues and so on. So the assessment is with the distal pulses, but what we must understand is the presence of distal pulses does not exclude that there was no vascular injury in dislocation. So early identification of vascular concept is the most important one, and most important sensitive index is ankle fracture index. That is, if the ankle ABI, fracture index is less than 0.9, we will always think that there must have been some form of a vascular injury. The vascular injury can be even intimal damage after knee joint dislocation, and that may lead to thrombosis, which you will see only later on. So after the initial assessment, you go for the radiograph, which shows which direction the knee is dislocated, what are the associated fractures with the knee dislocation, and it also aids in the planning which direction you are going to pull the knee joint. So the treatment is to address the immediate problem, addressing the issue causing the hypoxia. That is, tissue hypoxia is an arterial injury, vascular compromise, whether the dislocation, though you are reducing, persistently reduced, or knee joint dislocation is associated with one of the serious problem, which is compartment syndrome, which is often missed. So always think when you have knee dislocation, you have a vascular injury, peroneal nerve injury, and compartment syndrome, which have to be looked for. And you reduce the dislocation, you are taking as much as possible, split the knee, and then reassess the vascular status and neurological status. So if you look at the algorithm, if you have a distal pulse which is absent, you you have to clearly take the patient to the operating room and start exploring the popliteal artery because already the damage is done. But if the responses are there, but if there is an issue with AVI, which is less than 9.9, go for arteriogram. Don't wait because there is some intimal damage. It can lead to thrombosis later on. If you have nothing, then you can put a splint after dislocation, observe the patient involved, and then you can reassess. What you reassess is these injuries are associated with multi-ligament injuries of the knee. Because emergency setup, only you need the knee dislocation to be reduced, but this has to be properly assessed and an orthopedic surgeon will take over the care. So knee dislocation involving many of the stabilizers of the knee joint. There are usually 4 ligaments around the knee and these 4 are dislodged and the knee stabilization is lost. So what do you mean by the multi-ligament injury? Knee is associated with 4 main ligaments when 2 or more of the 4 primary stabilizers are lost, we call it as multi-ligament injury. So for a depiction, all of us know what is ACL, but one of the primary stabilizers of the knee is posterior cruciate ligament or PCL, which is just behind the knee and which is a very weak ligament which stabilizes the knee. And also the medial collateral ligament. Many times we don't give much attention to the MCL, but this is a primary stabilizer for the knee to go into balance and on, right? And then the other one is we always think there is only lateral structure, which is lateral collateral ligament, but there is a complex of structures which we call it as posterolateral corner, including the posterior capsule, popliteus tendon, lateral popliteus ligament, everything is involved. So the knee dislocation or multi-dislocation is associated with all these ligaments. So how do we do? For us to identify whether there is a problem with this ligament, we need to know some classification. It's always better that we classify. And then there are several classification systems. So based on the classification system, we treat the multi-ligament injury. So this treatment, what I am saying here is give you an overview so that you know that there are treatment modalities after knee injury or knee dislocation, and these patients can be put back to the sports or whatever the normal status at the end of the day. So what do you do with acute management, like what you need for the dislocation? You reduce the knee, assess the vascular status, reassess the physical examination with X-rays, anesthesia, and you splint. And then the emergency management is over. But the management is not over there. Then we let think whether you can just splint it or we let go for some other thing. If the knee dislocation is associated with an open injury, open knee dislocation, or if there is instability of the knee joint, where after reduction the knee is not staying in position, or if the knee dislocation is associated with an arterial injury, where the vascular surgeon wanted to do an arterial repair, we let go for a spanning external fixation. So splint is not the answer in every knee dislocation. We may have to go for an spanning external fixation. So the arterial injury which requires surgical treatment has to be combined with prophylactic fasciotomies because, as I said, compartment syndrome is one of the dangers and limb loss is the end result. And the other thing is when you have fracture dislocation, you don't go to address the ligament immediately, you treat the fracture. So you put the knee into an external fixator or spanning external fixator, treat the fracture, and then think about the ligament reconstruction. And we have the isolated nerve injuries. And what we have to understand is many of the nerve injuries are fracture injuries, they recover. But if there is no improvement of the peroneal injury, then you will be handing over to the other departments like nerve conduction studies and then rest of the things. So what we do when we have a multi-ligament injury, that is our task with knee dislocation. Subsequent treatment is the one which is important to increase the stability. You can do it without surgery or surgery. But what was found is surgical repair or surgical reconstruction of the multi-ligament injury of the knee give a better repair followed by a good rehabilitation rather than knees which are managed conservatively. What happens at the end of the conservative management is many times they end up in stiffness, arthrofibrosis, and also instability. Therefore, most studies favor reconstruction of the ligaments. So, what we do whether it is repair versus reconstruction is questionable, which will be addressed by the orthopedic surgeon. Many times, what we do, ACL or PCL, we can reconstruct, and even we can reconstruct the posterolateral corner. These are the X-rays depicting a multi-ligament knee, which was reconstructed in all aspects. So, when do we do? Is it in the emergency? No, it's not in the emergency. you have got the knee in the correct position, you wait. How long you wait? Ideal time, you shouldn't be doing it within 3 weeks, you wait for 3 to 4 weeks after injury. In surgery or the multi-ligament injury is considered after 3 to 4 weeks. So you are studying time in the emergency department for you to manage this and to hand over the orthopedic surgeon and for them to go on. When you do it early, within 3 to 4 weeks, the tissue plates are much better, but there is a risk of fibrosis. So the ideal time falls between 3 to 6 weeks, but not before 3 weeks. So you can have a variety of grafts. You may wonder how do you repair this reconstruct the knee ligament injury. You can have a hamstring graft from the same patient, or you can have a quadriceps graft, which is a current training cervical quadriceps tendon, or you can take a bone pattern graft. But at the end of the surgical procedure, as in any trauma, rehabilitation is the one which takes the priority. So there should be an accelerated post-operative reconstructive rehabilitation program for knee dislocation. That is, if you have reconstructive cruciates, you have to quickly get the patient after the surgical repair to maximize the quadriceps function and hamstring function. What you do, your knee is kept in extension for about 2 weeks, non-medial for 6 weeks, you have multiple injuries, and then you start progressive kinetic thing and you continue brace for about 12 weeks. So, knee dislocation is a serious injury with associated popliteal artery injury as well as peroneal nerve injury, and there is a risk of compartment syndrome. Early and appropriate surgical intervention where reconstruction leads to an improved outcome in comparison with the non-operative management. Rehabilitation protocol is one of the most important ones and are more gradual and it has to be tailored. Thank you very much.